Doctors, we are live. You can start the session.
Good evening, folks. A very warm welcome to everybody to this first ever Solves India webinar, which is focused on subthreshold micropulse laser in macular pathologies. Now, the source or the subthreshold ophthalmic laser society was the brainchild of a few like-minded people across the globe who felt that this technology, this therapeutic modality, which has been around for quite some time, needed to come to the forefront. And to that effect, to discuss threadbare the techniques, the potential, the role, and possible applications of micropulse lasers, we put together a group of eminent retinologists who have had considerable experience using this technology over the years. So without further ado, let me quickly move over our chairpersons for the day, Dr. Victor Chong, president of this SOLS Society, and one of the leading luminaries and voices for micropulse laser over the years. He had headed the Department of Eye at the Oxford Eye Hospital, has been the editor of Focus and Eye Associate Editor for more time, over 100 publications, and is currently based in San Francisco. So welcome, Dr. Victor. Dr. Girdhar, our other chairperson, needs no introduction. Has been the founder, the medical director, and mentor at one of the leading eye centers and retinal practices in South India, the Eye Institute, and has been a past president of the Visual Retina Society. On the panel, we have Dr. Lita Wu, an outstanding retina specialist, a very academic individual who's been one of the founder members of the PACORS, the Pan American Collaborative Retina Study Group, which has brought out so many erstwhile studies, multiple awards at the ASRS and other national international societies, on the editor of various eminent ophthalmic journals. He's been the past president of the Pan Am Visual Retina Society and current vice president of the Pan Am Association of Ophthalmology. Dr. Ken Fong, another doyen in the field, a good friend and a strong supporter of VRSI programs over the years, the current president of the APAO, the Asia Pacific Academy of Ophthalmology, and he's going to be overseeing and organizing the next APAO meet in Kuala Lumpur next year. He's the immediate past president of the Malaysian Society of Ophthalmology. And then we have Dr. Raja Narayanan, again, somebody who really needs no introduction in this forum, the current network chair for human resources and the clinical director of Sven Research Center at the Delhi Prasad Eye Institute, and was former honorary secretary of VRSI, and is somebody whom I've really enjoyed working with in our past tenure. And moderating the session with me today, Dr. Jay Shablani, a consultant clinician at Pittsburgh Eye Center, and somebody who has a humongous number of publications and has authored a textbook on choroidal disorders, and one who has his finger in many pies and has been championing micropulse lasers with us. So welcome to everybody. We also have a number of speakers. We'll introduce them as we go along. So let me quickly introduce and welcome and invite Dr. Victor Chong, our president, to say a few words and get this show on the road.
Yeah, good morning, good afternoon, and good evening, everyone. I think that we got certainly myself is very early in the morning, and then Ken and some others are very late in the evening. And well, welcome to the SOLS India webinar. I think that my understanding is that there's more people than just from India attending the meeting. And I think like Dr. Allen mentioned earlier, that there has been the technology has been around for more than 20 years. In fact, that like my first paper on this is more than 20 years old. I think the technologies are maturing now, and we have now more and more study confirming that this less might be actually better. So without saying anything more, that I would hand back to the moderator, so as we can actually get on and start the session. Thank you.
So thank you, Dr. Victor. I may now invite Dr. Ken Fong to begin the show. I will talking on subthreshold micropulse laser, the need, rationale, and principles. Dr. Ken Fong.
Thank you, everyone. Thank you, Anand, for the kind invitation. And I'm just going to share my screen. Just give me a second. Okay, so my presentation is up. I'm going to switch to presentation mode. Okay, so basically, I'm just going to give a quick introduction to the role of subthreshold laser. I've presented on this many times in the past. I apologize if some of the slides are repetitive, but I think it's as what Victor has mentioned, it bears repeating because this is a very unique modality of treatment for our patients who have macular diseases. And I think as we will see from the other presentations to follow, it will become more relevant in the years to come for several reasons. So these are my financial disclosures. I've a consultant for Quantel Medical for many years and helped develop their subthreshold laser systems together with many other doctors. Together with Victor, Vite, Jay, Alejandro from Spain, we were the original co-founders of the Subthreshold Laser Society, and I'm very pleased that Anand has agreed to take on the challenge of leading, being a committee member with us, and this is his. I thank him for organizing this important webinar. So why do we still need laser for macular diseases? First and foremost, I think we can see that many countries, India included, Malaysia included, even US, UK, Australia, they cannot afford continuous unending intravitreal injections. And we have hundreds of webinars about fixed PRN, treat and extend, which anti-VEGF to use, how often, and so on and so forth. And now we have companies talking about doubling the dosage of the anti-VEGF or longer acting agent and so on and so forth. But it becomes a huge burden to our health economy. And cases of diabetes are increasing worldwide. We see that everywhere, DME. And interestingly, CSR cases are also on the rise, as well as proliferative diabetic retinopathy. There are many cases we all have come across that are unresponsive to injections, whether it's anti-VEGF or steroids. And we often wonder whether if we had treated them initially with laser, could they have had a better result? So what do we really mean by subthreshold? I think this is the crux of the argument that we have all over the world. Everywhere I go, I have doctors asking me, what do you mean when you do this and so forth? And even before the webinar, we had quite a good discussion among ourselves about our different parameters. And Jay will follow up with a recently published guidelines endorsed by the society that we feel will be good as a baseline to follow. So subthreshold laser really means you cannot see any visible changes during the laser procedure. And if you use fluorescein angiography, OCTA, autofluorescence, you can't really see any changes. You have certain software like the endpoint management with the Pascal TopCon, whereby you can see a visible scar at the beginning, at the end of the laser burn. There's also technology by Alex where they use 2RT, very high power, but very short nanosecond durations. But what I'm referring to is really the pulsing technology that Victor has mentioned has been around for almost 20 years. Initially introduced by Iridex, and they called it, it's been trademarked as Micropulse. But other companies such as Quantel, ODOS, and Lumenis also have similar pulsing technology called by different names. So we use the word subthreshold to encompass all these different modalities. And as a whole, the society believes that they're all pretty much the same, no matter what one company says or the other. We feel that pretty much it's a similar sort of technology whereby they chop up the laser beam. What are the main issues with subthreshold laser? Number one, all the published studies use different parameters. They might use 5% duty cycle, they may use 10%, they may use 15% duty cycle. Some use a fixed burn power, some use titration of the power. And there's a high risk of undertreatment. If you are starting up, you're often very scared of increasing the titration of laser power to cause a scar. Very often, as we see, laser is often used as a last resort after failure with anti-VEGF or steroids. There are no published studies comparing subthreshold laser versus anti-VEGF. However, I believe the Diamond study has the initial results of the Diamond studies has been reported at a recent Macular Society meeting, and we look forward to further details on that, whereby subthreshold laser was used together with anti-VEGF for DME. So how does subthreshold laser works? It works by changing the microenvironment through stimulation of RPE cells. So if you see here, if you do a traditional full fluence laser, you kill the RPE cells, you have a dead zone and a sublethal zone. And the dead zone is where you see the initial white burn, and the sublethal zone is where the burn will extend to over time as a scar. You really don't need to kill any RPE cells, but you need to elicit enough energy to get a response in RPE cells to increase the production of matrix metalloproteinase inhibitors. And these, we believe, is the biological effect that helps improve the functioning of the RPE cells and reduction of edema. So this is the current treatment parameter I use. I believe Jay will go that further on that, but I use the OCT guided thickness map at 5% duty cycle. I do titrate. Basically, I do a visible burn outside the macular area, and then I reduce the power by 50%. I use a 160 micron spot size with a dense pattern and treat the thickened areas that I see on OCT and evaluate at 12 weeks with OCT. You can or cannot use you may or may not want autofluorescence. It's not really necessary. And how is it done? You choose, we have the pattern scanning option on our laser machine. So we choose a variety of patterns. So here you can see on the left, area of thickening on the OCT. I have it printed out when I'm doing the laser on a patient in the room. But I think some of the companies have now, you can actually overlay the OCT on when you're doing the laser machine, and a lot of more options now. And then you remember where it's the thickening as you do a normal focal laser. You mark the area, and then you titrate the power, and then you go ahead and then choose reduce the power by 50% and treat the area. So it's suitable for many types of DME. Clinical significant extrafoveal is perfect. Fovea involving, I often do it in combination whereby I inject anti-VEGF first to reduce the thickening, and then top it up with some laser over the residual areas of thickening. Here are some useful cases that Dr. Alejandro Rios from Spain has published upon. I think it's very useful to share. Here's a case of extrafoveal edema. At 1 month after subthreshold laser, you see a reduction in the thickness, and at 3 months, there's further reduction with no need for any anti-VEGF treatment. Here's a clinically significant juxtafoveal edema, 1 month after treatment, a good response, and 3 months after treatment, further reduction with no need for any anti-VEGF treatment. So you can see a color picture side by side. There is a reduction of the exudates, but it's probably some worsening of the overall diabetic retinopathy. This is for more advanced users. In cases where you have fovea involving good vision, the patient had some anti-VEGF treatment given, and then a top-up with laser around the residual thickening areas. Here's a case of laser after intravitreal injection. So you can see here there's some more edema, infranasal, and top-up laser was done at 3 months. CSR is also a very common topic that we are seeing, and I think we'll have some cases presented on that. So I think Dr. Lee Tae-woo is here, and he'll be able to share further on the Pathologies study that he and his team has published on. One common discussion is about the PLAY study, which was conducted in Europe, where they showed that PDT was superior to subthreshold micropulse 810 nanometer laser. But our argument is that the wavelength chosen is not something that we would recommend. Most places are using the 532 or 577 nanometer laser, and we believe the wavelength is important. And the Pathologies study showed that that was actually better than half dose PDT for CSR. So I won't go to this. I think Lee Tae will present it. But what it showed really, subthreshold laser group had a much larger percentage of more than 3-line gain from baseline compared to the half dose PDT group. Here's a case whereby you have an acute CSR of less than 1 month duration, and you just treat the hotspot with a subthreshold laser using the same parameters as DME, and there's a good resolution. Here's a case from Victor many years ago, a patient of chronic CSR. You can see the hypoautofluorescence on AF and the chronic thickening here. Multiple hotspots showing diffuse leakage. Subthreshold was applied all over the leaking areas, and using the same protocol, and there was a reduction in the fluid, but the vision did not improve much due to the chronicity of the leak. So I would encourage all of you to check out our website, solslasersociety.com. We have many international members, and we are developing protocols for the different machines and running clinical trials for multiple conditions. So in summary, it works. All of us are here today. I think all the case presenters will have good experience to share what their experience with subthreshold micropulse. You have to treat the whole area of thickening and be very dense. Don't go above 10% duty cycle. You need to be patient. A perfectly performed laser takes between 6 to 12 weeks to show its effect. And we believe that yellow subthreshold laser has a more beneficial effect than half dose PDT for CSR. It's certainly very cost effective and should not only be considered in rescue situations. So in conclusion, please come to Malaysia. We're going to have a special workshop, instruction course, and several seminars on this modality in February next year. Thank you very much.
Thanks, Ken. It was fantastic presentation. Anand, you are muted.
Sure. Go ahead, Jim.
Yeah, so very nice and lucid presentation and a great foundation for the rest of the talks. I think something very important you brought in was the term called subthreshold. I think there have been a lot of, I can't find a better word, confusion about this term. I think what is more important for all of us who are using this technology is to understand what is the difference between subthreshold, subliminal, sublethal. These are some very important terms, and I think overall, I prefer sometimes to call this as a retinal restorative therapy, where you are not actually destructing any retinal tissue, but because subthreshold laser helps to prevent the destruction, that's why we should call it as a retinal restorative therapy. But with this, I would say, does anybody has any questions for Ken? Any comments on the basics of subthreshold?
Hey, can I ask a question?
Please.
Yeah. So, Ken, you said you titrate the power. So when you titrate the power, you use the power in a micropulse mode or in a full
in micropulse mode. So I use that 5% duty cycle. I choose an area outside the macula. Normally, if it's an Asian eye, I would start at about 600 to 700 milliwatts. If I see a mild reaction, then I know I'm there. I reduce it by half. So on the laser machine I just press the button 50% and immediately reduces the power by 50%. So it's normally between 300 to 450 milliwatts at the subthreshold power at 5% duty cycle that I use to treat the thickened areas.
One more question. When you do this test one, it's a single spot or it's again a gray?
Single spot. Single spot, yeah.
Lita, you had some comment?
Yeah, I wanted to add that the reason why yellow wavelength is better than 810 is that because it allows titration under the micropulse mode. If you use the 810, it's really hard to get the burns to be seen. So that's why with the 810, you probably, if you wanted to do titration, then you probably had to do it under conventional continuous wavelength. And that's where sometimes you get into problems because you forget to turn the laser back onto micropulse, and then you end up doing a continuous wave treatment. So that is one of the advantages of using the yellow wavelength.
I have a question to Ken. Is there time for that?
Please go ahead.
Ken, just one question, because all these topics are going to be covered in the course of the seminar, but I just thought I'll ask you now, in diabetic macular edema, do you treat all patients with micropulse? That is, even after the anti-VEGF as a routine? Do you practice micropulse as an add-on therapy in all cases?
Yeah, it's a discussion with the patient. Those who are extrafoveal, who good 6/6 vision, I think they're perfect candidates for laser. You don't have to start injecting them so early.
Yeah, that's okay. But I'm talking about patients with center involving DME.
Yeah, I would still give anti-VEGF.
Yeah, after the anti-VEGF, do you routinely also give micropulse in all your cases once your edema is reduced, or you pick and choose patients?
I pick and choose. It depends on the residual thickness and how they're doing. I do use Ozurdex quite a lot as well, because I find that is also good therapy. So not all DME patients get it, but again, it's a question of discussing the choice with the patient. And a lot of patients actually are needle phobic and also find it a lot of hassle to come for regular injections. So if you have that option of laser that is helpful, I think they would also like to consider that.
Victor, can you just add on to that? I mean, do you have anything to say?
Yeah, so I think that like what Ken said, when to use it, who to use it is, I don't think that we have universal agreement. And whether that we consider doing it for every patient is always a discussion that we seldomly do anything for every patient, right? So I think that's why physicians make decision. And even then, like Ken mentioned that he tend to use the anti-VEGF first before the laser. And I actually tend to do the laser, first and then before the injection. Or even on the same day, we do the injection, when we do the laser and then the injection. The reason is like there's a pros and cons for that. I think Ken is right that if you do the injection first, then you reduce the edema, and then you can do the laser more precisely. On the other hand, that laser do take a little bit more time to work, so you have a kind of temporal sequence. So if you think that you can manage to do the laser, if the edema is not too much, now again, appreciate that in different country, the presentation is different. And in the UK, where I used to practice, that because of the screening program, they tend to come in a bit earlier, even with century involved. So it might be there is a difference that I were able to do the laser when there was still some edema. And then it helps because then the laser start to work, while the injection is also working. So I think that's a pros and cons that depending on the patient.
Yeah. So one last question by Raja. Raja, you had something to say?
Yeah, so I'm mindful of the time too, but very nice opening actually from Ken. A lot of questions and great presentation. I still would like to, over the course of these discussions, we'll need more level 1 evidence for different diseases. Different diseases have different mechanism of pathophysiology. Some are at the level of RP choriocapillaris, some are, let's say, microaneurysms and diabetic macular edema, where I still believe that we may have to, one laser or one parameter may not be able to solve everything. But I like the basis with which Ken started, that intravitreal injections, chronic and repeated, how long can we sustain this kind of injections? It's a strong basis to work out these. But I still believe that for each disease, we may have to come up with different protocols. I think Jay will be talking about it. I hope he will be talking about it later. But there are questions about which laser, what parameters for different diseases.
Sure. So to answer all those questions, we'll move on to Jay, who will be speaking to us for 10 minutes on SALT's treatment guidelines, the target, titration, and technique. Jay.
Great. Are you guys able to see my slides?
Yeah.
Okay, good. All right. Thank you so much, everyone. Good evening, good morning, and good afternoon. So I'll be talking about subthreshold laser therapy guidelines for retinal diseases on behalf of SOLS Society. And I will just give you the brief introduction how we came about this. These are my financial disclosures. These are my financial disclosures, and none are relevant to the SOLS Society. So before I really jump onto the guidelines, I would just give the brief introduction that SOLS is Subthreshold Ophthalmic Laser Society, with the goal to facilitate the discussion between specialists and professionals in this industry, and to overall encourage the research opportunities and innovative collaboration in subthreshold laser field. These are the founding members. This all started in somewhere in 2020, where we started talking about this, and there is certainly a need. And then we have an executive committee spread across the globe. We have many experts around the world, and it's really glad to work with these smart guys who have so much experience of with subthreshold laser. So with the aim of this society, we have established this website I just brought in when Ken was mentioning, is that this website is pretty much just being built up right now, where we are trying to bring more educational videos and important publications, which will help us to our readers, viewers, as well as building up the research opportunities. So today I'll be talking about the subthreshold laser therapy guidelines for retinal diseases, which we established on behalf of Soul Society. Why do we need guidelines? Because subthreshold laser has been utilized in clinical practice for more than 3 decades. There have been numerous randomized and real-life studies which have proven the efficacy and safety of this subthreshold laser in various retinal diseases. However, despite of decades of usage, we still do not have a standard protocol for subthreshold laser applications and settings. And as you saw that as soon as we started the webinar, there was so many questions about the basic settings for subthreshold laser. So we really wanted to establish a consensus guidelines for subthreshold laser therapy in retinal diseases, for which we had 12 experts. We established 43 questions, all spread across the different settings, applications, and particular diseases. In the first round, we sent across these questions and we obtained responses in the masked manner. And then we had 2 virtual meetings in which we discussed about each and every question and what should be our consensus guidelines. Before I really jump onto the guidelines, I would specifically say that these guidelines are independent of any specific laser device. They are very much towards the subthreshold laser, as Ken mentioned very clearly that whether it is Micropulse by Iridex or microsecond by Nevilas, they all fall into one category as per the expert, that is subthreshold laser. So let's start with diabetic macular edema. It's one of the challenging diseases. However, the Souls expert believe that there is a role for subthreshold laser in both center involving as well as non-center involving with or without adjunctive anti-VEGF therapy. We recommend 5% duty cycle with 200 millisecond pulse duration and 150 to 200 micron spot size without any space between the laser spots using an integrated pattern system. As Ken was mentioning, we support that we should do the titration using subthreshold laser, and wherever you get the threshold power, just cut it half to 50% and use that power as your subthreshold micropulse laser in 5% duty cycle. Souls expert recommend applying these laser to edematous areas. However, it does not mandate any focal treatment for microaneurysms. Continuing with diabetic macular edema, we all believe that transfoveal treatment is safe. However, we need to reconfirm the subthreshold laser safe settings before applying. We do not recommend any specific structural imaging studies to evaluate the laser spots because we believe it is a subthreshold laser. If you used the correct settings, you really don't need to, you should not have any structural damage. However, we would still recommend that during the follow-up visits, you can perform non-invasive techniques such as autofluorescence or OCT to evaluate if you are seeing any laser damage on these structural imaging modalities. We recommend follow-up evaluation at 6 to 8 weeks after the subthreshold laser. However, repeat subthreshold laser is suggested after 2 to 3 months of initial application in case of poor response. I would just like to emphasize that what we are promoting or discussing now is the subthreshold laser settings. We are not recommending treatment for diabetic macular edema, seeing that the diabetic macular edema treatment can be performed as per the physician discretion, whether they want to add anti-VEGF therapy or steroid therapy in response to the subthreshold laser. These are very specific subthreshold laser settings, not the management of diabetic macular edema. That's because that's a much more bigger question and depending upon various factors. Let's move on to central serous chorioretinopathy. Souls expert recommend the subthreshold laser in both acute as well as chronic types. For acute CSR, we feel that considering the safety of this subthreshold laser, we would like to apply subthreshold laser 1 month if there is no resolution, unlike the conventional 2 to 3 months of observation. For chronic CSCR, Souls expert supports subthreshold laser as first line, as well as combination therapy with other treatment modalities. Again, we are supporting 5% duty cycle with 200 millisecond pulse duration and 100 to 200 micron spot size with titration in the same way of using subthreshold laser and applying 50% of the 50% of the threshold power. Settings are same for both acute and chronic CSCR with no spacing between the spots using integrated pattern system. Again, we support transfoveal laser application. We all have experienced safe outcomes with transfoveal laser application. However, again, you need to reconfirm the subthreshold settings before pressing the foot pedal. For acute CSR, we recommend focal leak areas and adjacent area. For chronic CSCR, Souls expert believe that we can perform laser for focal as well as diffuse hyperfluorescence seen on fluorescein angiography. Again, we do not expect there would be any damage because of subthreshold laser. However, performing autofluorescence or OCT could be useful in evaluating any laser damage. In patients with CSCR, we would like to evaluate the effect of laser in 6 to 8 weeks. In case of poor response or persistence of subretinal fluid, a repeat treatment with same settings is recommended. However, if physician believes that we can supplement and add additional treatment such as oral or other form of treatment, they are free to do so. Again, these were very much subthreshold laser settings. We are not recommending a treatment protocol or treatment algorithm for CSCR. These are the summary of the table. I would recommend that you should go through this publication, and they are very simple, straightforward settings. With this, I would like to conclude that these consensus guidelines do not suggest management of these diseases, but suggest laser application guidelines using different subthreshold laser delivery systems. We do not support any specific laser delivery systems. These are very much subthreshold guidelines. The goal of these guidelines is to establish standard subthreshold laser application in clinical practice, and we hope to start various clinical trials to establish level 1 guidance, level 1 evidence for these subthreshold laser in various diseases. This publication came out in this is, I believe, open access. So you all can go through this publication and give us your feedback and share your experience. Thank you so much. And I would like to acknowledge all the Souls experts in working with this publication and helping this to establish these guidelines. Thank you so much for your attention.
Thank you very much, Jay, for crystallizing, the principles and the treatment guidelines. I think this is something which everybody, has on their lips. What are the guidelines that we should follow? There's a lot of variability. One of the reasons this technology has really, taken off is because people don't seem to have that consensus. And hopefully, as we move forwards with these kind of guidelines, we'll have more clarity there. So I think one thing that comes out is that one of the key things is that we need to be flexible with the power that is delivered, and that we understand that Asian eyes are not the same as Caucasian eyes. The level of pigmentation is different. This laser as such act because the power is delivered in micropulse bursts at the RP melanosome level. That's where the uptake is, and so you need to keep that energy low. So in Asian eyes, the pigmentation is more, and therefore they would perhaps behave differently and require different power settings compared to, say, Caucasian eyes. So that is why we believe that the power titration, as opposed to a fixed titration, as all of us believe the consensus, is required. And what we recommend is, doing that titration with the subthreshold power with your duty cycle at fixed at 5%. And then once you get that, then you slip down to 50%, and you should be fairly good. So comments from my other panelists, Dr. Victor, what would you say?
Yeah, so I think that Lithia has already mentioned that titration wasn't possible in 810. Certainly in our first very original paper, we titrate with 810 by using continuous wave. So the correction is actually not as accurate. So that's also why that there was a limitation there. And I think that you also look at the people, the expert who kind of suggesting continuous, and to see actually what their population are like. So we started doing some of this in King's College in South London with a very mixed population with a lot of Caucasian, a lot of Asian Indian, as well as African American or African Caribbean patient. So we think that titration was important. However, that if you practice that when I moved to Oxford, then when it is really kind of 95% Caucasian, and then most of them don't have cataract or already have cataract surgery. And then, the titration probably less meaningful, partly because they virtually end up at very similar power. So sometimes that, I sometimes that even myself was a little bit lazy to do titration on a very clear lens and, and a fair Caucasian race. So I think that might be the experience in some of the colleagues who suggest no titration is because if they got a very, kind of population like the one that I had in Oxford are mostly Caucasian, mostly with no cataract. But I think that might not be applicable for the rest of the world. And I think that your comment is like, yeah, certainly that we do see pigmented eye can get a titration lower power. So again, at least that is meaningful in a way. And whether that Caucasian, that if you had to use the same power all the time, whether that you would be overdone in some of the pigmented eye or other way around that you undertreat. So I think that is something that we felt titration is useful. It takes extra couple of minutes, I think that for the sake of the patient, I think it's actually worth doing it, in particular when you have a mixed population.
Absolutely. We take a quick question from the audience. Dr. Aditya Verma, is there an end point when subthreshold laser is done? Jay, you want to take that?
I think that's again an important question. Like we discussed, that if I understood correctly, is that we really want to use the subthreshold laser, go where you actually start seeing a very faint one that becomes your threshold, and then you cut it to 50%. Say that your threshold came at 1200 or 1000. This is the usual 5% duty cycle threshold which we get, and then cut it to 50%. That is 500 or 600. But you have to make sure that before you really press the foot pedal, make sure that all the settings are perfect and it is in the micropulse mode. We have had disasters just because we missed out the settings, or we missed that it was not moved into a micropulse mode.
Yeah, thank you. We have a number of other questions. I think most of them will be answered when the talks come through. So in the interest of time, we'll move on. So it's my pleasure to invite Dr. Lite Wu to speak to us on subthreshold micropulse laser in central serous chorioretinal. Dr. Lite.
Thank you, Dr. Anand. Let me share my slides. So I'm going to be talking about our experience in Latin America regarding the yellow subthreshold laser versus PDT in eyes with chronic central serous chorioretinopathy. These are my disclosures. Note that I've been a consultant for Quantel Medical. And most of you already know that CSCR is characterized by choroidal hyperpermeability, pigment epithelial detachments, and retinal neurosensory detachments. In most patients, there's spontaneous resolution. However, in some patients, the disease becomes chronic with ensuing visual loss. So we decided to see what are the treatment possibilities in these eyes. And one of them is photodynamic therapy with verteporfin. So verteporfin PDT has been used to treat these eyes. However, PDT has some adverse effects that include a transient reduction of macular function, RPE atrophy, choroidal non-perfusion, and even the formation of secondary choroidal neovascularization. So in the hopes of doing that, some investigators try using either half-dose verteporfin or half fluence of laser light for the treatment of these eyes. And this is a paper that was published by our colleagues in Taiwan, and they used both PDT protocols, and they showed that these were effective in improving the best corrected visual acuity and eliminating subretinal fluid. However, despite these modifications to the PDT protocol, choroidal hyperperfusion still occurred. We in Latin America then decided to compare our experience regarding both PDT and yellow subthreshold laser at 12 months of follow-up. because many years ago, about I'd say around 10 years ago, we did not have access to verteporfin. For some reason, the companies decided not to supply us with verteporfin anymore. So that's when we decided to do the switch about 10 years ago or so. So we looked at these sets of patients, and this was a retrospective comparative study of 92 eyes that were treated with either yellow subthreshold laser and 67 eyes that were treated with half-dose PDT. We defined chronic CSCR as persistent subretinal fluid for 6 or more months. And these are the laser parameters that we use for the subthreshold laser. As already been mentioned, we use a duty cycle of 5%, a pulse duration of 200 milliseconds. And this is something very important. We did not have any spacing between burns. So this was indeed a high density treatment pattern. And the spot size varied from 100 to 200 microns. We did power titration as already described previously. And in our patients, the powers range anywhere from 320 milliwatts to 660 milliwatts. And so in our group, there were many who used the Quantel laser, but also there were also many that used the Iridex laser as well. So this was pretty much laser independent. With the PDT, this was the half-dose PDT. You're familiar with this, 3 milligrams per meter square of Visidyne, 15-minute infusion, laser activation for 83 seconds, and the spot sizes range anywhere from 400 to 2,000 microns in diameter. Ken already show some of these results, but I'm going to go through them again in a little bit more detail. Here is a table where we look at the baseline characteristics. And basically what we wanted to show was that both populations of patients really were well balanced at the beginning. And you can see regarding age, duration of symptoms, the mean central macular thickness, subfoveal corneal thickness, and the visual acuity, they're pretty much well matched in both groups, so there were no differences. With regards to the 12-month results, you can see here the outcomes in both groups. So you can see here the subthreshold baseline and the results at 12 months, the PDT group at baseline and the PDT at 12 months. And you can see that there were statistically significant differences in both groups with regards to the central macular thickness, and the subfoveal corridor thickness was more pronounced effect with the PDT group compared to the subthreshold laser group. And the visual acuity, it was much improved in the yellow laser. However, in the PDT, there really not much difference in terms of the visual acuity between baseline and at 12 months. So if we look, dissect this a little bit more regarding the visual outcomes, you can see here that the gains and distributions of the visual acuities favored the laser, the yellow subthreshold laser compared to the PDT. We had more gainers, 3-line gainers in the yellow laser compared to the PDT. And the rest of, in terms of loss, it was pretty similar. Here's a curve showing that. You can see that the logmark curve with the PDT was pretty much flat. So the PDT was actually pretty good in maintaining visual acuity, but not too good in improving the visual acuity. In terms of the yellow laser, you can see that it was sustained, and actually after 3 months is when we started seeing some statistically significant differences in visual acuity, improvement with regards to the baseline, which was maintained at until 12 months. These are the anatomic outcomes using the central macular thickness as a surrogate. We can see here that the PDT was able to drive more the fluid in these eyes than the subthreshold yellow laser. In terms of recurrences, we can see that with the yellow subthreshold laser, we had more recurrences, almost 25% compared to the PDT, which was 10%, with a mean range of 1.35 treatments, with a range of 1 to 4 treatments in the laser group, compared to 1.2 treatments with a range of 1 to 3 in the PDT group. However, these differences were not statistically significant. In terms of complications with the yellow subthreshold laser group, we didn't find any. In the PDT group, one eye developed choroidal neovascularization, and this was treated with 3 intravitreal injections of bevacizumab. Let me show you a couple cases. This was an eye that underwent yellow subthreshold laser. You can see the ICG. Here are the areas of hyperpermeability, the OCT showing the subretinal fluid. Baseline visual acuity was 20/80. Following the laser, we can see that the visual acuity improved to 20/30. The subretinal fluid was gone. And this is an example of a patient that underwent half-dose PDT. You can see the fluorescein, the ICG, and the OCT with fluid. Patient had a visual acuity of 2200. And following the PDT, you can see that the fluid goes away, the vision improved from 2200 to 2070. So yes, the PDT also can improve the visual acuity in some eyes. It's also an effective way. And if you guys want to check out the details of the study, we published this at the BAJO a number of years ago. So how does our study compare with the rest of the literature? This was another study that was performed in Europe, and you can see that it was very similar to our study. 42 eyes treated with a yellow subthreshold laser, 58 eyes treated with half-dose PDT, and this group of colleagues from Europe also showed that the yellow subthreshold laser was more effective in eliciting a response than half-dose PDT. However, we have come across the PLACE trial, where it was a randomized clinical trial. And unfortunately, in my sense, this was not performed correctly. And I'll tell you my personal biases with this. So this study were 89 patients where you had half-dose PDT compared to 90 patients with the Micropulse laser. The Micropulse laser was 810. With power type, they didn't do power titrations. They had fixed power settings, and you can see them listed here. And supposedly they said this was high density, but and then they showed that the high dose PDT, half dose PDT, was superior to the Micropulse laser, both in functional improvement and complete resolution of subretinal fluid. So based on this trial, they just buried completely subthreshold laser, at least in central serous retinopathy. But again, we have to look at the details. And they said in their paper that this was supposedly high density. We sent the letter to them, and they told us that the laser spots were positioned adjacent to each other in a non-overlapping fashion. However, they did not use a multi-spot pattern scan. And that is a problem, because if you realize all these burns are invisible, and if you do not have a pattern, how can you really be sure that your burns are next to each other without leaving any open spots? So this is a major problem that I think really influences the effects. So my feeling is that in the Micropulse laser arm of the PLACE study, the eyes were undertreated. So in conclusion, both half-dose PDT and the yellow subthreshold laser are effective in restoring the macular anatomy in eyes with chronic CSCR. However, it appears that yellow Micropulse laser has a more beneficial effect in visual acuity than half-dose PDT. Thank you very much for your attention.
Excellent presentation, Lite. Very nice.
Thank you, Greg.
Great. So we have a couple of questions from audience. Let's start with them. We have a question from Dr. Mazumdar from Delhi. Her question is, should the amount of retinal edema not be factored in the titration? Do you have any comments on that?
Well, I think in your guidelines paper, we said don't bother with the amount of edema because, I think the target is the RPE. And since this is going straight, if you focus correctly, it shouldn't really matter.
Okay. Yeah, that is true. That is true. And considering the nature of the subthreshold, we really do not want the adjacent temperature to be raised. That's why we really don't care about the amount of edema there. So the next question is from Dr. Aditya Verma, that can you please explain the reason why should there be no spacing between laser burns? Does it decreases the efficacy of laser?
Yeah, so we are extrapolating really from a paper that was done by our colleagues in Brazil, where they looked at eyes with DME. This paper was published in IOVS, maybe 2014, 15, around that time. And they actually looked at 3 different groups. One group was conventional ETDRS macular grid or modified grid. And then the other one was Micropulse with high density. And the other one was Micropulse with not high density. And when you compare those 3, both the anatomic and the functional results were much better in the arm that had high density. So that's how I feel that maybe you really need to treat the whole area, and when you're not really treating the whole area, then you run the risk of undertreatment.
Yeah, true.
I just had a question. When there are areas of EED, RP, atrophy, fibrin, would you modify your grid or skip around it when you address this, to avoid any kind of complications, do you think?
No, I don't. I feel like since this is really subthreshold treatment, it shouldn't really matter.
Yes.
Yeah, true.
I think Rohan had a question.
Yeah, Rohan.
Thank you. So I just wanted to ask, in suppose of case of fresh CSC, you have a clear-cut single burn, a single leak, and you have decided on your laser settings. So when you hit on the leak, do you just give one spot or do you repeat it 3-4 times with the same setting?
Well, if it's just a single leak, I think you can treat it many different ways. So, if you want to treat it, if it's subthreshold, I don't think it really matters. If you are going to do regular laser, which is an option if the leak is really far from the center of the fovea, then probably I would just do one direct shot there. But for acute things, and I just use the same. I don't modify the settings.
Okay.
And I think that's the benefit of doing subthreshold laser, because so you can actually do a little bit few more spots around that area, because it's not going to cause any scarring. Yeah, Dr. Giridhar?
Yeah, a nice presentation. I had a few questions to one is, in one of the indications for micropulse as far as CSR is concerned is one is subfoveal leak. Are the parameters the same as what you do outside the fovea, or do you have a different parameter when it comes to a subfoveal lesion, number 1? Number 2 is in chronic CSCR, where you don't have any focal leakage in your fluorescein angiogram, do you advise ICGA to identify areas of leakage and treat them with the subthreshold laser? Because that's what I do in some of these patients, where I identify the areas of leakage in ICGA in midface and treat those areas with a subthreshold laser. Because otherwise, we really do not know where exactly to treat.
Yeah, so regarding the foveal leak, I do not modify. I think what Jay said is very important. Before pressing the pedal, you just have to make sure that your parameters are correct and that you are indeed in the micropulse or subthreshold mode prior to doing that. Otherwise, you might cause some problems. With regards to using ICGA, yes, I use ICGA in a lot of these eyes. The problem is that ICGA is not widely available. That's why, I guess in the guidelines, Jay didn't mention it, but ideally, I think ICGA is superior than fluorescein in terms of determining the zones of hyperpermeability.
Thank you.
Okay, you had a last comment.
Dr. Ajay Rera, you have any question?
Victor wants to give a comment. Victor?
Yeah, so I think that I want to comment a few things on the past few questions. I think the titration is important, that you need to kind of learn that in the beginning. I think that Jay mentioned that already, but I think I want to reinforce that you want to be powerful enough that you have effect, and then also not powerful enough to see any scar afterwards. So I think the initial, when you're first starting, that's quite important to titrate that. Because I think that we talk about cutting down by 50%. So if you actually wait until to see a very clear, visible burn, you might want to cut it down more. I think some of our colleagues that want to be more confident to see the burn, and then they cut it down to 1/3. And again, the original 50% is partly that I think that it's easy for me to divide the power by half than by 1/3. So I think those are something that you might want to audit your initial result when you first start doing them. And then secondly, that once you have, and also to reinforce that the test burn are out in the outside the edema area. So I don't know whether that question was whether edema matter or not. So because you're not testing in the edema area, because I think that's also important. And again, just like Jay and Lucia already mentioned, that on your first burn, so to speak, or probably first spot might be a better word, that you might be just want to make sure that is, when you turn down to 50%, you are become not visible anymore before you start treating. So there are all these kind of things that you don't tend to do anymore when you're very experienced. But in the beginning, I think those are good practice. And similarly, don't touch the fovea in the very beginning. But I think once you get your titration sorted out, you know what you're doing, then I think then it's quite safe to do so. And similarly to the question about whether you want spot or a few spot for CSR, and indeed that I tend to treat a little bit bigger area than the lead gauge for CSR. And again, that's controversial. Not everyone agree with it. I'm happy to treat a little bit more, seems to give a slightly better result. And indeed, when we publish a paper that if we do that a little bit extra, seem to have slightly better result. Not that scientific, to become a more personal preference. And again, also go back to the question about you can't really get a dead cell when some of the area they already got RPE atrophy. Those are dead cell, and you can't really make the dead cell to be stimulated. So I think sometimes that you treat a little bit beyond, although you might be normal retina, but again that might also help to inducing the response that we want to see. And finally, the question about overlapping, I think that is really, certainly when I was training fellow, one of the common mistakes is people tend to undertreat because they come with the history of treating with conventional laser. As Ken mentioned earlier, that in conventional laser, you had the scar, which is a dead zone, and then you had the ring around it, which is a subthreshold zone. That was a biological effect. And so you do need to have spacing, because if you don't have spacing with conventional laser, you basically kill all the retina. And that's actually how the concept worked without thinking about it way back in the years. But obviously with subthreshold laser, you don't need to do so. And you actually can put it next to each other. And then we're kind of combining the biological understanding as well as the clinical data Lucio mentioned earlier, that's why that we're actually suggesting, very, very close by, and it's easier to do that with with pattern laser for that matter. And then finally, the way back in the days that we actually have deliberately hit a same area 3 times to see whether that you can actually see a spot, and appears to be that you can get it up to 3 times, you still get away with it. So I think that there's also in the beginning, a lot of colleagues are worried about a little bit of overlapping. And I was suggesting a little bit of overlapping is not a problem once you actually have get the titration right and also audit your result. And if you actually have too much overlapping, then you will see scarring as well. Then obviously that was not right. So I think, the reason that Micropulse or subthreshold laser are not get adapted to, because you need to change your behavior a little bit. I think that just same thing that when many of us are changing from extra cap to phaco, I think that we do things quite differently. And I think the new generation, just learning from phaco from the start, actually easier. And in fact, there's people who never done laser before, find doing subthreshold laser much easier. And Ken mentioned that about the diamond study. We're actually trying. The paper should come out very soon. I think it get accepted. And we're actually planning to changing, very inexperienced people to do this methodology. So it's a little bit of training, but I think once you know how to do it, it's actually much easier than even conventional laser.
Thanks, Dr. Victor, for those insights. Yeah, I think we should move on. We are getting a little backed up now. So it's my pleasure to invite Rohan Chawla to speak to us on Micropulse laser in diabetic macular edema. Rohan's an additional professor in AIMS RT Center. So.
I'm unable to hear Rohan. I don't know.
Yeah, Rohan,
You are muted.
Can you hear me now?
Yeah, but
Yes,
your slides have
great.
gone out.
Okay. Now can you see the slides?
Yes.
Yeah, sorry. So I'm thankful to Dr. Anand for inviting me to this meeting and Solve Society. So as all of us have been discussing, there's a lot of confusion about subthreshold laser, and I might be adding more to the confusion. But the very purpose of this meeting is that we should have different viewpoints first across, and then we can come to probably some guidelines. So something about subthreshold laser in diabetic macular edema, what has been my experience. So there are no financial disclosures from my side. So we've already gone over the rationale. I won't take much time on it. So basically we are trying to avoid the thermal damage and apply the minimal laser irradiance and also allow for some cooling time. And why we just don't reduce the energy, and why do we add also the apart from the duty cycle, why have we reduced the duration also? Because there is a risk of this micro explosions if we do not reduce the pulse. So that is the additional thing. Not just the energy amount is reduced, but the energy pulse is also reduced. And as we have also discussed that there are various treatment options for DME, focal and grid laser and anti-VEGF agents. And a protocol I has shown that maybe the adjunctive laser may not add to the benefit, but it reduces the intravitreal injections. And probably that is what is our again aim with the subthreshold laser, to reduce the number of injections, as was mentioned in the first talk today. So which laser also we have had a small discussion. So now people are mostly moving towards 577 nanometers. So regarding DME, there have been a lot of publications. I think a lot of people on the panel here have some of these. I've just mentioned quite some of them. There are a lot more. To summarize quickly, what are the key points from these studies, which I found was that when we compare to conventional laser, there is an effect on central macular thickness with about 10 to 12% reduction, similar to conventional laser, and no scarring is seen. And this effect is definitely more if the edema is 400 or less. If it is much more advanced edema, then the effect is less. But again, the laser energy duty cycle cutoff varies across the studies. So how do we decide the cutoff? So from when I started doing laser, I went to this animal study where they found that no damage could be seen if the energy level was kept less than 30%. If it was kept between 30 to 50%, then there was some damage to the retinal pigment epithelium visible on electron microscopy, but again, healing was subsequently seen. So, but they found that less than 30%, there was no effect at all, not visible on any of our imaging modalities, as well as on electron microscopy. This is an animal study. So we also did a small study to study the effect of subthreshold laser on diabetic macular edema. But for the ethics approval, currently, we cannot do away with the standard, what is the standard therapy, that is the anti-VEGF therapy. So we took patients who had already undergone some amount of anti-VEGFs and were still non-resolving. And we compared two protocols. In one, we used 5% duty cycle, and in the other, we used 10% duty cycle. But here, I did not use half the energy was more. So actual terms, the 5% was delivering 10%, and the 10% duty cycle protocol was actually delivering around 20%. But still, I was well below the 30% cutoff, which I showed you in the previous study. So I have given a test spot not in the micropulse mode. So this is something learning from me from this webinar. In future, probably I would now try to do the test burn with the subthreshold micropulse mode itself. And like I told you, so sorry, it was 5% and 15%, but we had doubled the power. So actually it became 10% and 30%. And we applied this laser in sort of a grid pattern. So I have, since I'm using a higher power, I was not going subfoveal here. And I repeated the same pattern at least twice in most of the patients. So like I said, we involved patients who had non-resolving edema for at least 3 months, despite more than or equal to 3 intravitreal anti-VEGF injections. And we had a follow-up done after 3 months of our subthreshold laser. So these are the basic parameters which we used. And we also did some quantification of hard exudates, which I'll come to later. So in our study, we did not find a significant change of best corrected visual acuity between the two groups. The central macular thickness did reduce, but it was not statistically significant. We also counted the hard exudate pixels, which I'll just show you how. Now, this did show a statistically significant reduction. And in the other group in which we had lesser energy, there also the hard exudate count did reduce, but the central macular thickness, unfortunately, rather increased. So just to show you an example, so you see the pre-laser photograph where you can see the hard exudates, and the post-laser, even just on the color photograph, you can make out that there is a significant reduction in the hard exudates, though the central macular thickness overall in the study did reduce with the higher power, but it was not statistically significant. So this is a technique we devised where we did some image modifications using image J, using some filters, and then thresholding algorithms where we could highlight these hard exudates much better and count each pixel. And so you can have a pre-laser pixel count and you can have a post-laser pixel count, and then you can do an appropriate statistical analysis. And so this way we found that, yes, definitely the hard exudates reduction was much more marked in our study than the central macular thickness reduction. So the conclusions I would say were that definitely there was no visible laser induced damage. We also did autofluorescence for that, and we did not see any damage in that. But we had taken resistant cases. So perhaps these cases were already resistant. That is why we did not find much gain in visual acuity and not a very significant reduction in CMT. But like I said, we definitely found a reduction in hard exudates. And so again, I think using these lasers, as our main aim is to reduce the number of injections, our thought process probably has to change a little. Yes, probably this laser will never match the efficacy of an anti-VEGF agent. But in many cases, is total drying necessary in diabetic macular edema is something which we have to consider. Perhaps a little bit of few cysts remaining there, and still if the patient is maintaining a visual acuity, the hard exudates are reducing, and the subsequent follow-up does not show an increase in central macular thickness, would also be probably an appropriate therapy for such patients. Like we used to be doing earlier, when we used to be doing conventional laser, and at that time we did not have OCT. So even at that time, probably after the laser, even in the patients who benefited, probably had we had OCT on that time, at that time, some cystic edema would have been present. So I think that thought process somewhere has to come in to reduce the number of injections and still maintain a significant good visual acuity for our patients. So we are planning further studies where we are planning to compare it for focal leads, not just in a grid fashion. And also we're trying to improve on our protocol for quantifying these hard exudates. So definitely, I think it has a role. And yes, with such webinars and such many more papers, we would finally be able to narrow down to a particular protocol and when not to use this laser as an adjunct to probably other therapies such as anti-VEGFs and steroids. Thank you. Thank you for a patient hearing.
Excellent. Thank you so much, Dr. Rohan Chawla. It's very nice and very interesting to see the resolution of hard exudates as well, which becomes one of the important parameters in various treatment modalities. Any quick question, comments?
Rohan, are you repeating in the same area second time the grid, dense grid?
Yes. So like I said, I did not, in this study for the grid, I did not do transfoveal. It was like a modified ETDRS grid, but I placed the spots twice.
Okay, even I am doing that in DME. Any recommendation, Jay, regarding repeat grid on the same area?
Very interesting question, and this is where I particularly feel Nevelas plays a very interesting role, because in Neville, with the help of Nevelas, you are actually able to document where exactly you did the laser. I don't think there is any harm in repeating at the same spot, but I think at the same time, what we were discussing earlier plays an important role, that because if you really understand the concept of this subthreshold laser, you are not having any heat dissipation in the surrounding area. The adjacent area is not going to have the increase in temperature. That's why you are still able to, you should be actually able to perform the laser adjacent to each other. So I think if we start doing continuous, I should not use the word continuous, but I should say if we start doing the laser without any spacing, then probably doing the laser at the same areas may not be required.
So
but
we don't have, so we don't have Navilas, but I used a grid pattern of say 4 spots or 8 spots, and then placed them very adjacent to each other, and then repeated the whole thing again with the same settings.
And I agree completely. And while we were setting up these guidelines, we definitely had this in mind, that not everybody is going to have the documentation of the laser, particularly the subthreshold laser, where you could not see the laser scars. But by doing this, adjacent spots, repeating at the same areas, you may be having greater outcomes. I think we are really running out of time. I'll just quickly jump on to Raja. He has been quiet since the beginning of the webinar. Raja, quick comment on DME, your experience.
I just want to say I've been thoroughly enjoying all the presentations. It's like, I feel we should have more time probably to discuss more nitty-gritties, because ultimately we have to give to the audience and ourselves, how do we move forward? What to take home, what exactly, is there enough evidence to say that, okay, in these diseases, we will move forward and these are the recommendations. But what I'm saying is that, at least from Rohan's presentation, and Anand can probably add, from the mild study of Micropulse laser, where we use 577 Texel Fyridex, where we had 2 protocols, 4 arms, laser alone, Micropulse versus the continuous wave, and also anti-VEGF arm, where we had anti-VEGF with laser and only anti-VEGF alone. From that particular data, although we could not complete the study because of Avastin issues at that time, I would probably at this point of time say convincingly that I am not doing Micropulse laser in DME, given that anti-VEGF for the visual acuity benefit. Let's say if you have protocol T, aflibercept, the kind of gain you are going to get with the vision versus Micropulse alone. I mean, one message, at least clear cut, I can tell the audience is that don't think of it as a substitute for anti-VEGF. And I like what Rohan also mentioned in his conclusions. What we're looking for is a laser maybe a conventional laser versus a micropulse laser, can it reduce the requirement for engineering? And that's where Ken had started off his initial discussion itself. And I think that is something we certainly should look forward to going forward. Unfortunately, we could not complete that study from that particular angle. And also from CSR, I would totally, I'm in favor of doing a bigger RCT and prove that based on these settings, it is either non-inferior to PDT. At this time, we are not having PDT in India. And that's a big concern. And it's also more cost effective, easier to do. So if we can do and prove it in a proper RCT, that's what we have to tell the audience also, that, I think it's promising. And there are some, at least take homes that we can give the audience.
Yeah, I'll just quickly add that, yeah, I totally agree with Raja. We could not, bring that study to fruition. But I just also like to add two things. One is the USP of this modality is that you can do repeat treatment. And that is the USP. You can go over the phobia, you can go transfoveal, you can go over those areas. And it's exciting to see what Rohan did, which is a really standout thing, is that the RX rates actually reduced. That's one. Second thing I'd just like to highlight, there was a publication in the IGO from a Turkish group a couple of years back, where they compared aflibercept, PRN, loading dose, 3 doses, and then PRN versus combination, 3 injections, aflibercept and micropulse laser, and they found that it was more or less the same, but the number of injections were reduced with the combination. So just on that note, we'll come back to this again, and I think we really need to move on. So it's a pleasure to invite Dr. Ajay Arora, a leading practitioner in Delhi and one with a very innovative bent of mind, is to speak to us on this experience in subthreshold micropulse lasers in RBO, regional bacterial classifications.
So can you see my slides?
Yes,
Can you hear me? So thanks, Anand, and thanks, Saul, for this opportunity. And I've been using micropulse lasers since 2015. So I'll be just sharing my experience on, these are my financial disclosures. Basically on non-ischemic CRBO and DRBO. So all cases in the macular area, I did 5% duty cycle, and outside the arcade, I did 10% duty cycle. Titration was done in the micropulse mode, a single burn nasal to the disc. The power was brought down to 30% for the venous occlusions. For the acute CSR, I do 25%, and for the DME, it's 30 to 35%, and chronic CSR, it is 30 to 35%. I have used a multi-spot pattern scan with no burn distance, either 5:5 or 7:7. I still consider that macular thickness is important, and for me, the cutoff is 450 microns. I tend to bring down the macular thickness using anti-VEGF or steroids, and then use the micropulse laser. So I would not go into what has already been discussed. I'll probably skip these slides because I think this is just, so this is 76 years old. So these are cases. I'll just be showing you a lot of practical cases. 76 years male who is Army general, who was hypertensive, diabetic, had an operated C rectum. He presented with central venous occlusion. And he was very particular that he doesn't want an anti-VEGF in his eye. So he waited for almost about 4 months before he decided to go in for a micropulse laser. And that was in 9th July 2015 when he made the decision. His visual acuity at that time was 6/60. So we had treated him during this time with non-steroidal anti-inflammatory, and he was doing yoga and trying to do everything to get his macular edema down. That it was not down, he agreed for a subthreshold micropulse laser. So as per my protocol of the titration, I did it in the nasal to the disc, and we used 30 to 35% of the titrated burn, and 5% duty cycle was used in the macula. And beyond the macula, we used a 10% duty cycle, and this was done in all 4 quadrants. The burns were 200 microns of 200 milliseconds with no distance between the burns. So this is how it was 3 weeks post-op, 6 weeks post laser. The patient's visual acuity has improved to 618. And this is during a follow-up of almost about till about August, when his visual acuity had improved to 612. And you can see the reduction of the macular thickness over a period of time. This is the 23 years old female. So this is the second case of Biagio, who is non-hypertensive, non-diabetic, who had sudden blurring of vision in the right eye with normal blood works, the serum homocysteine of 7.1, with no past history of similar attacks. So she had come to us, and initially she was treated. This was in 2014 when she was treated with Avastin. This is a clinical picture, and she had improved. This is how she looked like at that time. And then again, the edema came back. This is 11 February 2015, when a repeat injection of Avastin was given. And she was very particular. She doesn't want any more Avastin. So this is in March 2015 when we decided that we go ahead with the Micropulse laser. And in April, we did the Micropulse laser. I plotted out the areas of how much of capillary non-perfusion was there. So we discussed with the patient the options of repeated intravitreal injections, or scatter continuous wave laser, or subthreshold Micropulse laser. When she decided, we went ahead and did a 10% duty cycle Micropulse laser to all these areas. So how do I know that I have treated the area? I marked out the area with the normal continuous wave, and then I filled up that area with the Micropulse laser, so that in case I have to repeat it, I have some boundaries marked out where I can actually treat. So please note this. This is in April 2015. This is the area of capillary non-perfusion. In August 2015, I could actually see some, I won't call it angiogenesis, but you could see some new vessels forming within that area. You can see all these areas have been marked out. So there was revascularization. We did a repeat Micropulse laser, again with 10% duty cycle. I have now followed up this patient for over now 7 years. And so she comes religiously every year. She's at the moment outside India. So you can see even the new patient had NVD, which gradually became more fibrosed. She had no conventional laser, only a Micropulse laser was done. And the conventional laser, continuous wave laser, was only to demarcate the areas where we treated them with a Micropulse laser. So this is over a period of time how the macular edema remains stable. And later on, when we acquired the angioplex, we have followed up on angioplex. And this is the montage of the right and the left eye. Now, what I want to point out here is 2018, this is what the macula was. There is a foveal thinning. This is the area of where there was a defect in the ellipsoid zone, which is about 528 microns, because she persistently said that though her vision was 6 parts, but she was seeing a distorted vision a little bit in the center, but she had significantly improved, and this is 2021. And this is the recent picture. She came back in April, where so I would actually ask later on ask the panel here that in the experience in such a cases, will it convert to a macular hole? Is there any point in operating at this stage, because the patient has about 6 parts vision, and a patient did develop a break in the infratemporal quadrant, which was later. This is a third patient. This is again a branch vein occlusion, a 39-year-old male with no diabetes, hypertension, was not vaccinated, and had no history suggestive of COVID. Presented on 7th May, that is when COVID had started in 2020. There was a diminution vision in the left eye of 636. The right eye visual acuity was normal, and that's what the macular edema is. All routine investigations are normal. Patient received an intravitreal injection of eccentrics. So this is how the patient was. This is 7th May, 13th May. 13th May, the patient received that injection. And this is what the patient was on 26th June. Visual acuity has improved to 612. Now this patient I have now followed for over 2 years. Patient is absolutely stable, has had a we did treat a second time of a micropulse laser, and this is recently when the patient had come to me. So we had given a 5% duty cycle in the macular area, and beyond that we went ahead and gave a 10% duty cycle. So this is the mid retina phase, the ANFAS image of in 6 September 2020. This is 14th July, quite recently in 2022, which is almost similar. Patient is quite happy with a visual acuity of 6/6 and has not been treated further, but is on a regular follow-up. So this is his recent angiogram and a wide field picture you can see here. So thanks a lot. This is why I wanted to share my experience with venous. Thank you.
Yeah, thank you, Dr. Ajay. Fascinating cases, especially that one in which you treated that non-perfusion area. Very innovative and a very nice thought that you went with the barrage to delineate where you needed to do that, and you found a bit of non-perfusion. I think that was quite remarkable. So, does anybody in the panel have experience, treating branch vascular occlusions, and especially ones that are ischemic, the way Dr. Ajay's case was?
I have done small tributary vein occlusions with naturally after injection 1 month later it will recur. I don't have a definite data, but initially there will be some improvement. I combine it with injections, so I don't know whether the evidence is towards micro.
Yeah, the macular edema, yes. I think many of us have, dabbled in
macular edema.
For the
Not
macular
for
edema.
periphery.
But for the non-perfusion, that was an interesting thought, and I think you showed us that even the neovascularization at the disc regressed too. So that was quite interesting. And in another case, you used a higher duty cycle for the peripheral areas. So that was an interesting.
I just wanted to make a comment. Very interesting work, and I am in favor of doing subthreshold PRP or subthreshold peripheral laser. We did a study when I was in LVP where we compared the peripheral PRP performed in one eye with the continuous wave and other eye with subthreshold laser, and we did find the benefit in cases of very severe NPDR, because we kept as progression of severe NPDR to PDR as one of the outcome measures. And it was very interesting to see that almost in a year follow-up, we saw that the eyes with subthreshold PRP also did not progress. And I think that Dr. Ajay Arora has also done peripheral subthreshold PRP in PDR. And maybe there is really a role for subthreshold PRP in reducing the neovascularization progression, as well as, it could be considered as every 6 months PRP. So you actually prevent the field loss, as well as you prevent the progression to PDR. Dr. Ajay Arora, you wanted to make a comment on this?
Yeah, so what I didn't present was that these patients which have done, I've also monitored that patient with a branch vein occlusion. I have a fields of 2015, fields of 2019, fields of 2021, where there are some changes which are evident. So I thought I'll present it at another occasion. But I've had 3 cases of proliferative diabetic retinopathy where we took the consent that we are doing the treatment which may not be the gold standard of not doing the conventional PRP. So for the NBE, I've done targeted laser, and rest of the area I've done micropulse laser. And now that I have a wide field angiography available at our own center, we will be able to monitor these cases much better. And I think the cases which I have, I followed them up. 2 of them I followed for 2 years, and they are doing pretty well. So I'm pretty excited about using micropulse PRP, but I've never gone to the level of
Dr. Girdhar, we can
security in the
in the interest of time, I think we'll move on. to a bouquet of a couple of very interesting cases. Dr. Mahesh Gopalakrishnan is first. A very interesting case. Dr. Mahesh.
Thank you, Dr. Anand. I will share my screen.
Lakshman has gone.
If I can make a very quick comment.
Yeah.
Personally, at this stage, I think based on the preclinical studies and the pathophysiology and how this laser works, I think I would like to limit the laser to within the arcades. But yes, like Dr. Ajay showed, maybe in future when we do more studies, we might come up with more further results.
Absolutely. This is not our current recommendation. This is where we are pushing the envelope, and it is fodder for further study. So this is not our recommendation right now, but this is where we push the boundaries. So yeah, Mahesh, please.
Yeah, actually, this is a case of 68-year-old man who presented with blurring of vision over 3 months with the metamorphopsia. Vision was improved to 6.9 with plus 2.5. And you can see that there is a large pigment epithelial detachment in the right eye, few pachytrusion. And this was the OCT. There is a huge serous pigment epithelial detachment with subretinal fluid on the edges, and little intraretinal edema was there also. The other eye has a pachytrusion, and this is different sections in the OCT. There are fluid all around with over the top of the PED also. So I did a multimodal imaging with ICG. Fluorescein angiogram is showing just slow filling PED, and ICG definitely shows a bunch of polyps in that notch of the PED area. And this is that notch of the PED. There was a bunch of polyps. So this was a standard PCV case with a notched PED. Had we had that photodynamic therapy, I could have. I have a similar case. I have done PDT with anti-VEGF injection, but since it is not available, I told the patient we will have either continuous injection or try this to reduce the number of injection. That is a subthreshold laser to reduce the injection. So this is multiple sections of angio and OCT. So left eye was unremarkable, and this is fundus autofluorescence. So Visudine is not available, so I advised injection. Patient preferred biosimilar cost factor, and injection was given, and after 1 week, subthreshold laser was given at the area of polyps. Actually, I gave a dense 5x5 at the area of the polyp, little outside also, not covering the whole PED with 300 milliwatt power, spot size 200, grid of 5x5. And I repeated it thrice because I was not sure whether some effect will come. Anyway, after 1 month, I had a shock of my life. This was the pre on the left side and post after 1 month on the right side. So it was completely flat, and the hypermetropia also reduced. The patient was reading 6.9. He was quite happy. And I didn't give the second injection. And after 3 months, it was maintaining same. There was no recurrence at that time. And he was quite happy. He was coming very regularly for follow-up. Last week, he came, and then that small pigment epithelial detachment has started again. Probably the BVN has started growing again. So this is the last follow-up at 6 months. So is it a good option for PCV along with anti-VEGF injection? I'm not talking alone. And all of us should think that micropulse also need to be repeated sometimes. Otherwise, like anti-VEGF injection, we have no worry in repeating. So micropulse also may be repeated sometimes. So these are some of the points that I would like to. Thank you.
Very
Thank
interesting.
you.
Very interesting, and I believe on at least on this forum everybody would agree to this. Raja, I believe, had done a couple of cases with micropulse in PCV. Raja, how was your experience in PCV?
Yeah, good to know that you remember that.
Oh, very much.
So actually, I had interesting cases where I had done micropulse laser for a patient where it was resistant to anti-VEGF. In this case, what you showed is, ranibizumab along with micropulse, and it worked. But in my case, it was about 4 or 5 years ago where I had documented the polyp on ICG, and even after multiple anti-VEGF, he couldn't undergo PDT because of cost reasons, but the polyp was still persisting, and then I did only micropulse to that area of polyp, and then I could document with ICG the polyp had regressed. So that's when it struck me that, oh, is this something which we can substitute for PDT? In fact, I wanted to do an RCT. In fact, I still have an IRB approval, but the problem is the kind of patients that we get to do an RCT where you do a PDT versus micropulse is extremely difficult. Either you need funding, and now we don't even have verteporfin. But yes, I think in this case, it raises the question that we need to explore this further. And if it works, I mean, anybody would take it. PDT instead of, I mean, micropulse or subthreshold instead of PDT.
I have advised repeat. Yeah, I have advised repeat ICG. I will do next week, and I will try one more repeat. That's what my plan is.
I have also dabbled occasionally in micropulse in cases of PCV, especially now the PDT is not there. But I've never seen this kind of a wow effect. This is really the kind that we started noticing when we started using aflibercept.
As far as that case is concerned, I personally feel there is no need to intervene immediately. I feel that this is a very small network that has come, and possibly I think you can observe and see. If it just remains like that, I don't think there is any need.
Yeah, actually, I am planning repeat ICG, and based on that, I will move whether to give a little more micropulses.
So Mahesh, Mahesh, a question: did you use a test one and reduce the power?
No, actually, I have been doing that around my machine. It works around 300. So nowadays I am not titrating. More or less, because I am getting reduced to half. I have done that repeatedly.
For clarification, you use 5% duty cycle, right?
No. This one I use 10%.
Yeah, because it wasn't written on your slide. So
yeah, 10%.
So great. Maybe we can move on to the next case. Another very interesting case by Dr. T.P. Vignesh, a colleague of mine from Arvind, Mumbai.
Yeah, I'm just sharing the slides. Just a minute. Yeah, I thank Dr. Anand and Sols for giving me this opportunity. My case is a case of bullous variant of CSCR, where I used eplerenone along with micropulse yellow laser subthreshold treatment and successfully managing it. 40-year-old male patient presented with defective vision in left eye of 10 days duration, history of similar complaints in the past, and history of previous laser treatment, left eye 4 years back and right eye 2 years back. No other positive history, and he was a mechanic by occupation. His BCVA in right eye was 6.9 and left eye was 6.24, anterior segment within normal limits. Right eye revealed an old subretinal fibrotic strand as well as few old laser spots and RP changes. Left eye had severe subretinal fibrin, dense subretinal fibrin, along with ILM folds, and as well as subretinal fibrin along the superior and inferior arcade as well. This picture shows the inferior bullous retinal detachment. And OCT of the right eye revealed a few RP changes as well as a PD and subretinal fibrotic strand. And the left eye revealed serous macular detachment with dense subretinal fibrin. And the below one, like just below the fovea, revealed multiple PEDs and the dense subretinal fibrin. The B scan revealed the inferior bullous retinal detachment. So I proceeded with combined angiography, and we saw like multiple leaks. You can see like along the arcades as well as just near the fibrin. So dense leaks were seen. So the treatment options that came to my mind were thermal laser, micropulse laser, PDT, and eplerenone. So the problem with laser was that since the fibrin was so dense, it may be difficult to focus and give the laser exact to the leaking areas. And so I decided not to go with the laser, and PDT is not available. The only option I had was eplerenone. So I did a baseline serum potassium. It was within normal limits. No other systemic abnormality was detected by physician. So I started the patient on tablet around 25 milligram once daily and followed up after 15 days. So here we can see a very good drastic reduction in subretinal fibrin as well as inferior bullous RD coming down. And we can see this decrease in the fibrin as well in the fundus photo as well. So now I started increase the dose of eplerenone to 50 milligram, and the serum potassium was still within normal limits and patient didn't have any adverse effect. So at the end of 1 month, there was further decrease in fibrin as well as the inferior bullous RD. At the second month, I could see like still there was decrease in the subretinal fibrin as well as the inferior bullous, but at the fovea, the fluid was persisting. So I repeated the angiography and then found that leaks to be reduced. Leaks have come down in most of the areas. So now I thought, since the fluid at the fovea is not being, why not to add micropulse laser? So now then I added micropulse laser after reduction in fibrin to the remaining leaks. The power I used was 300 milliwatts, duration 200 milliseconds, 5% tube cycle. Spot size was 100 and number of spots 140. So after 3 months, we can see very good reduction in SRF as well, and complete resolution of the inferior bullous RD. And we could see the remaining subretinal fibrous strand. At 4 months, there was like complete resolution of foveal SRF as well. So from baseline to the 4 months follow-up, there was complete resolution of the condition. We can see here the progress from baseline up to the 4 month and the OCT, and the bullous RD resolved completely within 3 months. So we all know bullous variant is a rare manifestation of chronic CSC, and this was first case of bullous CSCR wherein combination of eplerenone and micropulse laser was used and a complete resolution was achieved. Eplerenone and subthreshold micropulse laser produced a complete resolution of bullous CSCR in 4 months. The improvement of vision from 624 at baseline to 612 at the final follow-up in my case. A combination of eplerenone along with micropulse laser can be considered as a therapeutic option in bullous variant of CSCR. These are my references. Thank you.
Very nice, Vignesh sir. As always, your cases are very interesting. Considering the challenge of non-availability of PDT in many places, Micropulse definitely is setting up its role in CSR, and we all have experienced that the subthreshold laser works really well in CSR. But one thing which I think it was brought in the very early of this webinar was the application of subthreshold laser in presence of fibrin. Does it change your settings? I would not think so. I would just be using the same settings, because as we understand that you do not get significant inflammation in the areas where the subthreshold laser has been applied. So you really do not expect a significant reaction or scarring just because of the laser. Any other comments on Vignesh's case?
Yeah, I just wanted to comment on, I don't know how, I mean, like there is controlled trials suggesting that eviferin doesn't really make much difference. But I think that always the difficulty is, you know, in the controlled trial, you got a multiple number of patients coming in. And so whether that might be a specific case that, you know, when you got a more severe one, like the one that you have, less likely to spontaneously recover, whether that might be a role, you know, or we're using a preference. So I think it's something that we probably won't be able to see. And concerning about control trial for CSC, I think it's very difficult that PT, I mean, like the PACE study, you probably noticed on off the list that Oxford is one of the sites, but then I was not involved directly. And because the study was partly funded by Novartis by providing the drug, and also also using 810 laser. So I think that we wasn't really doing the study right in a way. But again, to try to repeat the study is almost impossible because Novartis would not fund it again. You know, and again, for people that who, you know, to buy the PDT, you know, to do a study again will be very difficult. So I think it's a realistic view of doing that. And even doing a study in DME, that the Diamond study, I was one of the grant applicants. It took us like 4 or 5 years to get the grant, you know, and then another 4 or 5 years to do the study. So we started that project almost 10 years ago. So it's very difficult to get people excited about, getting, grants to do it. And again, that was why that some of the reality, the real world data or a retrospective study are needed, So, but whether that as a society, we were hoping that we can actually do some pragmatic study. I think a proper randomized control trial might not be necessarily fully possible. But again, we welcome all colleagues, different idea, sharing information, sharing idea, and doing something that more pragmatic, as even the US, the DLCR net study are quite often very pragmatic. So they do have funding. So it's kind of like, I think we need to be realistic about it. We are still trying to persuade the DLCR net to do some of the Micropulse study. I think the Diamond study is certainly that one piece of evidence that the LCR net was keen to look at in more detail. So the Diamond study is very specific. They are looking at central remote DME, but they are very the edema was not very severe. So I think is a more similar to the protocol V, I think, but decided different parameters and so on, and comparing conventional laser with to subthreshold laser. So there's still a lot of things that we don't know about. Certainly that like even today, different experts are still using slightly different parameters and so on. So I think that is still something that I hope the guideline that we provide as a kind of like background, and then we explain the logic that why we're using those guidelines, and just hopefully that the guideline be adapted as time goes along, and then we were able to do some more pragmatic study.
Terrific. So I think, we've had a wonderful session. A couple of questions have just popped up. This one from Dr. Barbara. Thank you for keying in. To Dr. Vignesh, how do you know if it was eplerenone or the Micropulse which is working? I think you mentioned that you started with eplerenone because it was so bullous, then got the fluid down, and then you went in for Micropulse. Am I right? So I think that kind of answers the question that the whole idea was to get the velocity down and then go in with the Micropulse. And then there's a question from Dr. Janani about has anybody used Micropulse for juxtafoveal hemangiomas. So yeah, so has anybody tried that for juxtafoveal vascular tumors or EPT? So I'm not so sure. Yeah.
I mean, these are my initial thoughts. Interesting question, but I would think that, we need to really understand what is the pathogenesis of the fluid in a particular disease. If we really think about choroidal hemangioma, it is primarily because of the larger abnormal choroidal vessels, which is actually exuding the fluid. I really doubt that the Micropulse would be able to really work on these abnormal choroidal mass, because Micropulse, we are like trying to work primarily in the area of RPE or choriocapillaries, may not be very effective. I'm not sure if anybody else has any experience.
TTT can be tried. TTT.
Yeah, TTT can be tried. Yeah,
TTT we have tried and we've had good results. So the issue with the Micropulse is this pathology is quite deep. Micropulse works in the RP choriocapillaries area, so it might take care of the fluid from an exudation point of view. It won't address the primary pathology.
Yeah, there's one interesting question there, I think, from my colleague, Dr. Vyas. I think, why not try Micropulse PDA for patients with pre-existing traction? I think that makes a lot of sense. I mean, possibly. I mean, where we do not want to give aggressive laser, which can increase the traction, probably, I don't know.
I agree with Jyoti that, many times when we are doing PRP for these PDR cases, I'm more interested in looking at the posterior hyaloid, because if posterior hyaloid is really thickened and elevated, you would really not dare to do PRP, rather take the patient to the OR. So those are the cases probably we can consider this. Thanks, Jyoti, for a fantastic question.
Those would be the expanded indications.
No, but
Dr. Ajay, you have
Dr. Giridhar, on one side we are doubting the use of Micropulse laser for PDR. On the other side, we are saying that we use it in DRD, which I think is a little extrapolating.
No, I don't think we are talking about TRD. We are talking about patients with nearly normal vision, where there is a pre-existing traction, and a PRP may precipitate a tractional detachment. So there are many.
Yeah.
Yeah, you mean
that
for
is
the
what
TR.
we're looking at patients with very good visual acuity with PDR, where there is a pre-existing traction, where when you do a PRP, you can worsen. So probably in these sort of cases, we give very little of laser. So in such a situation, whether there is a role for this sort of this thing, that's what we are looking at.
Yeah, I think something to think about, but I think certainly my experience with micropulse PDR in general, not particularly the case that you're mentioning, is not effective. I think we said, at least I believe that for PDR you do need to kill some retina. I think the whole concept of micropulse, you don't kill retina. But again, just like most things that you can't be generalized in. That's why we talk about patient to patient. I think in very specific case, there might be reason for doing certain things, but certainly we have tried it when Jeff was publishing data on PDR patient or early PDR patient, and we actually even did up to 10,000 burns because of the more spot that you need to cover the same number of spot, and it's still not very effective. But again, we did a small number of cases, never publish it, because again, this is really a publication bias that if you don't think it will, you tend not to publish it, either. So I think it's still way to be seen. I think that my experience might be negative, and then we stop doing it. And also when anti-VEGFs come in, we tend to do combination therapy, but whether there's a role for combination therapy, whether there's a role for just treating the ischemic area with micropulse, again, that need to be still way to be seen. Nowadays, but again, it is slightly more difficult. I would say it's slightly more difficult than doing this kind of study in Europe and US, because I think that anti-VEGF are commonly used now in PDR patient, but might be something that can be done in Asia.
I just want to make a quick comment about Vignesh's case of bullous CSCR, because these were the cases which I would see very often in India, not that often here in Pittsburgh. But I think eplerenone, actually, I started using eplerenone in bullous CSCR very often, because when you have an exudative detachment, you have no other choice other than, you are not able to do PDT, or you have to take the patient for external drainage, which you would still be reluctant. If the eplerenone works, that's great. And in my experience as well, eplerenone did work. There was a question from audience that was it an eplerenone effect only, or delayed eplerenone effect, or the micropulse made a difference? To answer that question, I would think that once your eplerenone has worked and resolved the leakage, you should always be considering some form of additional treatment such as PDT or micropulse. And I'm sure Vignesh did not have the access to PDT, so he went ahead and did the micropulse, which probably is going to hold on the recurrence in these cases. So I think combination is certainly a great choice. Congratulations, Vignesh.
Thank you.
So on that note, I think we've had a scintillating session. I'd like to thank all the speakers for excellent talks. I'd like to thank our chairpersons, Dr. Victor Chong, Dr. Girdhar, and all our panelists, Dr. Lita Gu, Dr. Ken Fong, Raja, for joining in. Thank you so much. It's thrown up a lot of thought. It's thrown up a lot of new questions. But I think the effort is on to put out those guidelines, and I'm sure we will take it from here forwards and try to establish some sort of evidence, level 1, hopefully, and make this something of a means of giving us another form of finite therapy. So I'd like to thank everybody else who's joined in. Thank you all for attending. Thank you very much. It's been great.
Thank you so much.
Thank you very much.
Thank
Thank you. Thank you.